making informed, there we go, making informed choices, healthy choices about physical and emotional well-being. Another dimension of recovery is having a stable and safe place to live, or that home dimension. Having purpose, being able to engage in meaningful daily activities such as volunteering or caring for family, being creative, working, having independence, income, participating in society. And the final building block or dimension of mental health recovery is that of community, being able to build relationships and social networks that provide support, friendship, love, and hope. So those are pretty big concepts. And I'd like for us to meet a case study that I featured in a paper that I wrote in last year, I guess it was published, that focuses on Anne. And we'll be using Anne throughout our talk today for us to be thinking a little bit about how these 4 areas might relate to a person that we might be working with who has aphasia. So Anne is a 45-year-old female. She's a single mom who has a teenage son. Anne is employed full-time. She has a full social life that revolved around her work, friends, social groups, and a lot around her son's school activities. Anne also has a history of attention deficit hyperactive disorder. She's taking medication for anxiety, and she went to therapy to talk about herself and managing her own emotional health. So if we think about these areas of 4 dimensions of recovery, prior to Anne's stroke, she had a lot of control over her life. She was physically healthy and proactively managing her mental health needs with therapy and medication. She had meaningful work, volunteer activities, and cared for her son. Her home environment was stable, and she lived there with her son. And she had an opportunity to build relationships and social network for support, friendship, love, and hope through her various activities that she was engaged in and her family. So Anne had a stroke a couple of years later. She was 48 years old and she had her stroke. And when I met her, she was 2 years post-stroke. She was still single and her son was now in college, which was really exciting. She's now unemployed and on disability, and she was unable to keep her home that she was living in prior to her stroke because she can't pay her rent. And so she had to relocate to a new town to live with family, and has a pretty limited social life currently. Anne still has ADHD. She still has anxiety. Now, though, she also is coping with having aphasia. She's depressed. She's not taking her medication for ADHD or anxiety because they interfere with the stroke or the medications that she's taking for her seizures and stroke. She isn't talking to anyone about her emotional health anymore, and she really wants to see a counselor, but her aphasia is getting in the way. So if we think back to these 4 areas after her stroke, Anne has much less control over these 4 dimensions of recovery. She's now managing post-stroke with aphasia, in addition to her ADHD and anxiety. She wants talk therapy, but her aphasia is getting in the way. If we think about this from a purpose standpoint, she's no longer able to work or do the volunteer work that she was doing with her son because he's now in college. So there was a life event change that happened in addition to the stroke change. She's also in a new community. So she's not working, she's on disability. She moved in with a sibling who lives in a different town, and her son no longer lives with her. And regarding community, her friends live in the town that she used to live in. She's no longer really engaging with her work colleagues because she's not working. She has limited social networks for support, friendship, love, and hope. So I think if we think about the psychosocial impact of aphasia, communication barriers resulting from aphasia can really put up some significant challenges to being able to develop and maintain relationships. Not having healthy relationships can exacerbate depression and anxiety. Aphasia also can have a negative impact on quality of life. It can change how someone views themselves or their identity. That can be because they're not working anymore or because they view themselves as being disabled or an aphasia person. I hear a lot as people describe themselves. Feeling socially isolated and actually being socially isolated, as well as not being able to participate in many of the daily life activities that were important prior to having aphasia. A couple of other things for us to think about is that people with aphasia can have chronic stress, and chronic stress can impact people's ability to engage in life. So people with aphasia have reported increased stress-related emotional change that can impact quality of life negatively, but also can impact learning. Again, which I would say is central to being a part of a rehabilitation program, is we're asking our clients to use these new strategies or incorporate this technique. And so when someone has chronic stress, that might impact their ability to fully engage in a rehabilitation process and could certainly also be harmful to physical, emotional, and cognitive health. People with aphasia are at a higher level of depression than other people who have had a stroke but don't have aphasia. So depression, certainly can impact quality of life negatively, impact rehabilitation outcomes, and also can increase health costs. And the there's a lot of different numbers out there, but one of the numbers that I see quite frequently cited is that 70% of people with aphasia experience depression within the first 3 months post-stroke, and it can persist up to 1 year for 62% of individuals, and I'm certain that it extends out beyond 1 year. So this is a major sort of crisis that sometimes is not necessarily directly dealt with. I'm not here to teach you about depression or those sorts of things. I'm here to provide some resources. So I do want to say there's a couple of really great resources from a speech pathology standpoint. Jackie Loris Gore and colleagues wrote a great tutorial in the American Journal of Speech Language Pathology. And I had a conversation with Samir Ashi about aphasia and mental health and some of the work that he's doing at Shirley Ryan. So I've got a handout that we'll make sure that we get for all of you that has some of the links to these resources. So chronic stress, depression, anxiety. Anxiety can be also impacting individuals who have trouble with recovery post-stroke and can impact quality of life or health-related quality of life. And if we think about Anne's case, she actually came into her stroke having a history of an anxiety disorder, which she was managing, but that maybe is even more exacerbated post-stroke with aphasia. Morris et al. Talk about a citation of 44% of people with aphasia can experience anxiety post-stroke. So I just want to share a little bit I don't mean to be all bleak about things, because there are things we can do, but I do want to say that the impact of depression and anxiety on people with aphasia is significant, and it's also not typically a frequent focus of concern for healthcare providers. That's speech language pathologists and all of us providing support. So I do think it's something that's coming to the forefront within the last handful of years, but that we're still having challenges addressing that in the therapy room. Baker and colleagues talk about this as a double whammy, in that people with aphasia have to communicate their mood and challenges, or excuse me, have to navigate communication and mood challenges with limited psychological support. So that can be really challenging for individuals. And this goes back to maybe having choice again, and the important impact that having choice has in autonomy, but that people with aphasia report that they'd like to have the option of being offered psychological support, even if they chose not to pursue services. So, everyone might not want to pursue services, but knowing that that is an option is certainly something that people with aphasia have expressed, that it is not necessarily typically a part of the services that are always offered across the board. So the landscape of living with aphasia and the mental health challenges that present post-stroke with aphasia are significant. So what's our role in providing support and services? And I see that I have a lot of SLPs on the call here, and I also know that this is an interdisciplinary group. So I'm going to try to mix in a couple of different disciplines, and then also make it a little more broad as well. So if I start with my own field in speech language pathologists, we are the experts in communication and experts in supporting individuals in being able to navigate aphasia. We are just learning learning how to do this ourselves, and expanding our toolkit. So in a couple of surveys in the UK and also in Australia, SLPs reported that, yep, addressing psychosocial issues with aphasia was within their scope of practice, but they were limited in understanding how to actually provide that support. And some of the barriers that they listed in that were time and insufficient training, right? That's probably something that's pretty universal across disciplines, is that when something isn't being implemented, not having the right amount of time or having the right training can certainly be barriers for that. But even our own discipline of SLP is really struggling with recognizing that we need to do better at this, and now that we've recognized it, knowing how to move forward to support our clients and their families is important. One area of development that has been provided, there was a recent article by Shalise Sandberg and colleagues, again in American Journal of Speech Language Pathology, a tutorial to support speech language pathologists in providing counseling. It's a really great resource if you're interested in having a little bit deeper dive. And actually, our whole field of speech language pathology is just really recognizing it's not just within aphasia, but that across the board, we have counseling to support communication and swallowing impairments, but we don't always have the tools to be able to do that. So we have a special interest group that it says coming soon, but actually it has already been implemented, maybe for about a year now. And I bet some of you on the call are a part of that group. So but speech language pathologists often see themselves as this communication broker, where when we're on the rehabilitation team, we may be the one to be able to help have communication between clients with aphasia and other members of the providers on the stroke team. But we don't always have the formal training in psychological therapy to know what we're doing or feel confident in doing it. And as a result, people with aphasia who need mental health support often fall through the cracks. So Brooke Ryan and colleagues talked about some possible solutions for speech language pathologists or SLPs to address that gap. And one is to train mental health providers. And I put in green today and expanding that out maybe more to rehab providers on how to communicate with people living with aphasia, that this is a little bit broader audience than that, but that we need to take more active role in providing training to other individuals on our rehab team that interact with people with aphasia on how to be better communication partners. We also need to be better at collaborating with mental health providers. And again, I would say rehab providers in helping to understand what their expertise is and how we can implement that into the work that we do. And also speech language pathologists should be expanding their skills in psychological therapy. I don't want to get controversial, not doing high level psychological interventions, but there are some psychological interventions that are not only within the scope of mental health providers. So we'll talk a little bit more about that here in a moment. So that's the SLP group. I'm not sure if there are any mental health practitioners on the call today, but maybe so, or maybe listening later. But this was a study that was done in Queensland, Australia, talking about how did mental health practitioners know what SLPs do, right? So part of the can we collaborate is do we know one another and do we know what one another do? And this, shows some of the barriers, I think, that, sometimes mental health practitioners don't have SLPs on their team. They did report what they knew, what they did, but that they didn't necessarily, when they were doing answering some questions related to a case study, weren't always understanding all of the essence of what speech language pathologists did. So I think that leaves, some area for collaboration in just getting to know one another. And I think that probably extends to other disciplines as well. So Odom and Barnett did a survey of mental health professionals in the US to ask, had they ever even heard of aphasia? 86% had. Could they tell what it was accurately? About 65% were able to identify that it was a language disorder. Over half had never provided services to anyone with aphasia. And many people reported low confidence in working with people with aphasia. So there's this, again, gap of people with the high level skills of providing mental health supports, not necessarily feeling comfortable, speech pathologists with the skills of communicating with people with aphasia, but not having the skills of providing the mental health support. So San Pedro and colleagues have talked about the need for addressing depression and mental health needs and developing services for people with aphasia in this area, and also acknowledge that this is challenging. It's easier said than done. Also reiterating that mental health professionals might not feel comfortable in providing services to people who have communication disability, in particular aphasia. And further, this article, I guess I'll have it as a part of the link in the handout, but it's an excellent reference for understanding depression in persons with aphasia, assessing, treating, and also increasing awareness about the life of participation approach to aphasia, which really talks about, instead of just fixing language impairment, takes on a WHO ICF of thinking about how environment and identity and participation really can be powerful to help support individuals in moving forward with life. So talking a little bit more about the role of the SLP in interdisciplinary support for mental health. I think this, really our job, and I do see a lot of us on the call today, is to take the lead, I think, in developing partnership with rehabilitation colleagues, learning from mental health providers about screenings for depression and anxiety or other mood disorders to support mental health and identify individuals who may need additional supports. But also then sharing about what aphasia is and how to communicate with people with aphasia, I think, is a really important aspect of our job. So I've talked about SLPs, I've talked about mental health providers, but what about other healthcare professionals? We have a number of individuals within ACRM beyond those two disciplines. So I pulled just a couple of recent references for us to plant some seeds and be thinking about a little bit. And I know this is a busy slide, but a couple of things. One, this study done in 2021 by Carragher and colleagues interviewed healthcare professionals in providing services to patients with aphasia. And it was an interview study with qualitative analysis, and the 5 themes are listed here for us. And I just wanted to talk a little bit about this because I think it highlights some of those challenges and hurdles. Healthcare professionals find communicating with patients with aphasia to be a negative experience. Can't say that this is generally speaking, but this was one of the top themes, right? It takes too much time and it's hard. Okay. Healthcare professionals don't know how to help. They are lacking the skills, and SLPs aren't always available, to help them with their strategies, and the strategies that we give don't always work. Okay. Also, healthcare professionals can limit conversations with aphasia because of some of these challenges. It's not that people don't have a good heart and don't want to help. They want to know how to help. And that some people felt like after they had training, it felt good to have successful communication, but that this is all really hard in an environment that we're fast paced. We have to get all of the billable hours and do all of the work related things. And so, we all who have had conversations with people with aphasia know that this takes time to be able to have a successful conversation. So there's some challenges here, and this paper identifies some ideas about how we might address that, which we'll get into here in just a moment. Another interview study, this time out of the Netherlands, primarily Netherlands, interviewed healthcare professionals and asked them what were some of the challenges, particularly with learning how to be a better communication partner and the training. They identified that sometimes the healthcare environment, the organization that we work in, makes it challenging to be able to implement the training that they had been learned to be able to be better communicators with individuals with aphasia. They also talked about that maybe expanding the roles of speech language pathologists from direct service care providers to more consultants to be able to help more people being able to learn how to be better communicators was something that came up. And then also that improving communication by increasing their knowledge and skills of other healthcare professionals. So again, this getting to know one another allows us to be able to collaborate more effectively, all in the spirit of supporting our clients with aphasia. And then finally, just one other article before I get into some of the ideas about how to support our clients that we're working with. But this was another article out of Denmark and the Netherlands talking about ways to improve communication and support healthcare centers And this viewpoint is from people with aphasia and their relatives. The other two studies were from the healthcare providers. But the people with aphasia are feeling like they just are not getting information in healthcare settings. They're having difficulty with understanding their practitioners, telling them and having conversations about their own health needs. Also that they feel like there was inadequate use of supported conversation techniques by healthcare professionals. There was a lack of shared decision-making in healthcare settings, particularly centered around goal setting, discharge planning, other really important aspects of being engaged in your healthcare. And also that support, guidance, counseling, and education is mainly targeted at the person with aphasia, but family members felt like they needed to be involved a bit more too, and would have liked to have been able to be engaged more. So wow, that's a lot of things that you know, are putting up some hurdles and some challenges. But I'd like to talk with you a little bit about some ideas and solutions that we might be able to think about a little more deeply. So what are some supports and interventions that we might be able to use to support people in living successfully with aphasia? So this stepped psychological care model has come out of the UK and is over in Australia as well. And I kind of likened this model to, when I think about in the school system, they talk about the return, like RTSS model, where like if you give something to everyone, regardless of what they need, that's level 1. And then each of the levels bumping up are a little more skilled, to where at level 4, you're actually getting an IEP for your special education services. So this model is very somewhat similar to that, in that level 1 assumes that all stroke survivors, regardless of whether they have aphasia or not, need support in being able to access supports and services for mental health or psychological services. Level 2 is a bump up then for, you know, mood screening and appropriate interventions for mood symptoms. And levels 3 and 4 then are those higher level skills that individuals with more moderate to severe depression would benefit from. So I'm going to say that in the speech language pathology literature, and I'm going to maybe extend it out a little bit and say that perhaps in the rehabilitation arena here, that particularly in level 1, we all can do better, and we all can help to provide more access to helping our clients, patients, people that we work with, however we're referring to them, to be able to have more supports for their psychological care. And to reiterate the study that I referred to just a few minutes ago, it's not just the person with aphasia who has the mood changes and challenges. It's also individuals who are close to them. In this case, a study on the perspective of spouses with individuals with aphasia, that they also felt like both themselves and their spouses were not supported with psychological services, and that they felt like they would really like to understand more and have some of those step 1 resources to be able to provide support. So I've got a few resources for you. The Center for Research Excellence in Aphasia Recovery and Rehabilitation at La Trobe, they call it Aphasia CRE is how you can search it, those sorts of things. But they have some really beautiful resources on optimizing mental health and well-being in aphasia. They also are fairly active on Twitter or X, that they push out quite a few of their new things that are happening here. And so I think they also have a YouTube channel where they host talks kind of like what we are having here today, and that you could go and listen and dig a little bit deeper into. Most of them are centered around aphasia recovery, and in particular, they have a high interest in mental health and well-being in aphasia. So but what I'd like to do for the remainder of our time today is talk about some of these level 1 interventions and give some resources that you might be able to integrate into your practice or think about sharing with colleagues that you are working with. So these level 1 interventions, remember that kind of assuming that everyone who has a stroke would benefit from access to these types of supports. Advice and adjustment counseling, mood screening, goal setting, support groups, stroke befriending programs where people who've had stroke go and support other people who are newly having experienced a stroke to have some resources and talk through things, music and art therapy, leisure therapy, biographic narratives, intervention, or using stories to support people in moving forward. So I'm not going to talk through all of these today, but I'd like to talk through a couple of them with you so that you're able to have a few tools and ideas to be able to move forward. So this is not an exhaustive list of screenings, but thinking about, like, instead of just assuming someone has depression or asking if someone is at high risk, using tools to be able to identify if someone is at higher risk for depression or anxiety, and then maybe being able to move forward with a referral for another practitioner. So some ideas there. Also, the support groups are a level 1 intervention. I think sometimes we think support groups are just nice to share with, but I think they're essential to share with all of the clients that we interact with. So where do people with aphasia turn to for support groups? I think it's these two top areas here. They look at the American Heart Association or American Stroke Association, now American Heart Association, and National Aphasia Association. I know Maura Silverman is on the call, the executive director of National Aphasia Association. But this is where I think people turn to. I think we can help our clients and patients be able to turn to that. But I would also say this: these support group finders are only as good as the information that they have in them. So if you have a support group at your facility or in your community that isn't listed in these areas, I think it's important for us to be able to make sure that these are out there so that people know how to connect with other people with aphasia. Another couple of great resources that are support groups but more online is the Aphasia Recovery Connection. It has over 20,000 members on a Facebook group. There are different groups, for people with aphasia. There's another group for caregivers and family members, but it's a way for individuals to connect and stay in touch. It's a pretty positive group interaction. I know we have Allie Reed on the call, who's been involved with ARC and also in the next one that I'm going to be talking here about in a minute. But this is a place where people with aphasia and family members can go. And, I might say even like with the support groups, with the Aphasia Recovery Connection, with this virtual connections that I'm going to be talking about here, maybe even if you're with someone, say, at your desk and you're providing support for them, ask if they'd be willing to have you help them sign up for the email listings or, become a group member or something. If they're not ready to do that, receive all the information at the moment that you're providing services, it might be information that would come to them at a point where they are interested in providing that support, and maybe you're no longer with them on a regular basis. So I would say, check out ARC or Aphasia Recovery Connection, as well as another community that's called Virtual Connections for Aphasia, which is something that came about during the pandemic. It's my silver lining. I think we all have a few silver linings of pandemic, and to me, Virtual Connections for Aphasia is one of those silver linings. Aphasia Recovery Connection and Lingraphica, which is a company that provides AAC supports for individuals with aphasia, brought together this community in the thought that it was just going to be a little something that was happening during this little pandemic thing. And it's blown up to just a beautiful, beautiful community. Allie Reed, who's on the call now with us here, is the director of that program. And they're free groups. They meet 2 to 5 times daily, 7 days a week, where you could have someone with aphasia be able to connect with a group. And if you don't like one of the groups, you could go to a different group. They're all very different. So I'd like to just share with you a real quick video on what Virtual Connections is like.
Hi, Manuel.
Hey, everybody.
Dee. Hi, Dee. Oh, you look so pretty. Hi, Cameron.
Hi.
Hello, everybody.
Hi, Bill. Ron.
How's everyone doing this morning? Good?
Good.
Good.
Okay. So
Excellent.
far.
So nice to see everybody.
Yeah.
With that, I think we'll get started because there's a lot to chat about. Aphasia.
I got aphasia January 9th, 2020.
Where are you
Yes.
calling from?
Albuquerque.
From the United Kingdom.
Welcome.
Okay.
Have you all done a virtual connection group before today?
Yes.
Okay. Do you find that they've been helpful?
Yes.
I think it's because of the situation, we've slowed down our conversation a bit and we listen much more closely to what the other person is saying.
We're just chatting away on a Sunday afternoon.
You're chatting away.
Happy or sad?
Happy.
Happy.
Watch it on.
Say what you want to say. You're beautiful. You're doing it great.
We're all different.
Woo! Look what I got.
Did you enjoy talking with other people with aphasia?
Yes.
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 Okay, if I can get this to move forward. There we go. So, so a really great space, a really easy way to maybe not take a lot of time off of you as the practitioner, but you can connect individuals with that. So here's a sample of what's happening in the next week or so on the Virtual Connections site. And another thing that I'd like to bring your attention to is Stroke Onward, which is a community that provides support for the emotional journey of the stroke recovery. And it was founded by an individual, Deborah Meyerson, who has aphasia post-stroke. And they're very engaging in an engaging community, but not necessarily a Facebook or support group community, but a great place to connect people with. So a couple of other things that I want to hit up on, and then I hope we have a little bit of time for some conversation. I'm not here to teach you about the WHO ICF. I know you all know about this, but I want us to think a little bit about WHO ICF and how we can change the environment to support people with aphasia in being able to have better mental health. So that brings up the idea of health literacy and eliminating disparities, having people be able to engage in their own health conversations and understand what's happening to them and be able to make choices. And so this, it's ideas of public health literacy and organizational health literacy to be able to support individuals in being active in their communication and their health. A recent publication is really doing a nice job linking how important conversation is to well-being, and how conversation is a vehicle to social participation, right? If we think about this is a happy hour, if we were a true happy hour, we would all be sitting around at a bar, having chats, building relationships, connecting with people that we knew before, accessing information, all of those sorts of things. And for people with aphasia, that is challenging. But communication partner training, or having people who are better skilled at being able to communicate with someone with aphasia, can really contribute significantly to mental health and well-being. So I want to bring your attention to a couple of resources. The Aphasia Institute out of Toronto has a free online training called Supported Conversation for Adults with Aphasia. They refer to it as SCA. You can go through longer trainings, but there's a dabble. It's about an hour. It's a beautiful online module for free that you can choose to take. You could have family members take it, you could have people on your staff take it, but to learn more about how to be a better communication partner with people with aphasia. And supported conversation really is all about acknowledging that a person with aphasia is competent, and then helping them to reveal that competence by getting the messages in, getting messages out, and verifying messages. So I'm not here today to train you on SCA, but just to plant a seed that if you're interested in learning more about becoming a better communication partner, this is one way of doing that. There are two other models that I'd like to share with you. One is by Burns and Baylor and their colleagues, called the FRAME model. This is kind of a nice quickie to help you remember that this is not necessarily made for people with aphasia only, but people with communication disability. But familiarizing yourself with how your patient communicates before you start the interaction, talking more slowly, assisting the patient with communication, mixing communication beyond just speaking and listening, and engaging the patient to respect autonomy. And then also the COMTIL model, which is a newer model. I put, and again, in my handout, I'll have a link to this information, but Jutta Isaacson had a conversation with me on the Aphasia Access Conversations podcast about this COMTIL model, which really is talking about, very relationship centered, that person to person in the middle, and then things that are in your court as a practitioner: slowing down, using a natural tone of voice, asking yes/no questions, and then also familiarizing yourself with how it must feel to, understand what that other person is like. And then the tools on the outside. So they're really saying that it starts with the relationship in the middle, and then how you modify your environment or yourself as being the environment, and then using pointing or the keywords or drawings or pictures. So a couple of other things I think we can be better at helping our people with aphasia, in carrying some sort of card if they feel comfortable, to help someone to understand that they do have aphasia, and that there might be ways that their person that they're engaging with for a conversation could be more supportive in that exchange. Then a couple of other things that I'd like to share with you. Again, thinking about health literacy as the universal precaution, right? And if we think about simplifying communication, making the healthcare system easier to navigate, and supporting people's patients' efforts to improve their health, this can be applied to people with aphasia as well. But that we do need to really think about written information, website information, verbal information needs to be modified for all. And when you make something what we call aphasia friendly, it really makes it easier for everyone, not just the individual with aphasia, but it does take time. So in my handout, I have some resources for written and print materials, using shorter sentences, maybe using a tool within Word or something to help you to reduce the level of difficulty that you're writing with, making key points, chunking information, using pictures and graphics and things like that. So taking something like that's on the left-hand side of the page and turning it to something that's on the right-hand side of the page, which still has a lot of information on it, but at least is a little bit easier for, I would say, all of us to read, but particularly more accessible for people with aphasia. In the handout also, I'll have some picture resources for you if you're wanting to build some things within this, and many of these are free and accessible. Using the teach back method, which I'm sure all of you are familiar with, but thinking about how that really plays into being able to verify someone understands something, not making it a quiz, but, helping them to be able to make sure that you understand that they understand. And there's an online module that is free also through this teach back mechanism if you're interested in doing that. Then just a couple more slides, and I know I'm at the top of the hour and maybe we'll have a couple of minutes for conversation, but something that I wanted to bring your attention to that maybe isn't on your radar is by Robin O'Halloran and colleagues. It's this if key, and I should have written it. We had a conversation with Robin on the Aphasia Access Conversations podcast too, but this talks about how healthcare providers can maybe help their hospital system or clinics make their environment more accessible for individuals with aphasia. So thinking about that as a resource. And then one last resource before we come back to Anne is Jackie Hinckley and Mark Jays did a really nice article in 2023 talking about resources for person-centered care for shared decision making, which they have some really great resources in there. And this is an open access article that you can check out. So if we think back to Anne, and how we might be able to support her in her mental health. We're not going to change the fact that she has had a stroke or aphasia, but maybe she's managing her ADHD and anxiety and depression with collaborative mental health and speech language pathology services. Maybe she's in a peer befriending program or is using storytelling for support in finding her purpose. She's still on disability. She's still living with her sibling in a different town. Son started college. We're not really changing much in that home environment. But now we've maybe got her on a local support group. She's in an online community, and she's beginning to feel that there's an instilled sense of hope and being able to develop friendships. So this is significant stuff. I think as rehab providers, we all have a role in advocating for our clients and managing their mental health and well-being. And it really is going to take all of us to be able to do this. So as I wrap up, I just want to say maybe, what do you think you might be willing to commit to? Learning how to be a better communicator with someone with aphasia, or training other people to be able to do that? Establishing a better relationship with an interdisciplinary colleague, or simplifying your language, connecting your clients to support groups and such. So thank you very much for your time today. I know you all are probably ready to head out, but I do have a little bit of time if you do for some conversation.
Katie, you said something about your handouts. How will we get those?
That's a great question. I don't know if I can just plop it into the, I don't know, I might, Susie, I might defer to you, but I'll see if I can just put it in the chat as a handout. I don't know if it'll let me or not, but I'll see if that works. So,
because it was really wonderful, Katie. Thank you.
And if not, I am more than happy to help figure that out too. We have your handout, you sent it to us, so we are good to go, and we'll make sure there's a way for everybody who was here today.
That sounds great. Yeah, and it's not letting me download anything into it. So we'll make sure that if you guys have a registration or something, okay.
Yeah, we'll try posting it. So perfect. This is just such an incredible topic. Mental health is clearly just really needs more attention for people living with aphasia. And I know we've all been personally just like privileged to work with people who are living with post-stroke aphasia, and just learning about what those mental health needs it's really highlighted what a major crisis is going on. So anyways, I just wanted to thank you for providing this information and the resources today to support all of us when we're working with people with aphasia. So thank you, Dr. Strong, for sharing your experience and your expertise with us. We have a few minutes left for questions. So you can either chime in or put them in the chat. I have seen a lot of side chat going on resource sharing, which is just fantastic. But if anybody has any questions, please go ahead and bring those up now. I'll start. I have one question. I really appreciated that you brought up how people with aphasia can sometimes fall through the cracks. And the approaches that you suggested were a lot had to do with training rehab providers and collaboration and just expanding our skill set. So I'm just curious if you have any experiences supporting the training of rehab providers, or if you've seen this done in settings that did it well, just what that looked like.
Mm-hmm. Yeah, I mean, I think it's really variable depending on where you're at. I think one model that we can look to is the one out of Denmark with Jutta Isaacson, that they actually, it's a small enough country that they are actually training, and they have a healthcare system that is across the country, but they are actually training all of their healthcare providers who interact with individuals with aphasia on this CompTIL model. And so I think that might be something for us to keep our eyes on, that it's kind of a train the trainer model where they're going through a certain type of training, and then it's not just speech pathologists that are doing the training, it's others as well. But I do think it just starts small, but it's also with any kind of training, it's never a one and done, right? There's always turnover or ways to deepen or those sorts of things. But there are other great models out there too.
Thank you. Any other questions for Dr. Strong?
When would you ask a colleague about trying medication, and does it matter in your experience?
Jeffrey, I heard the last part. Are you asking about like asking colleagues about, I'm not sure if I completely understood the question.
Yeah, you talked about level 1 interventions, and
yes,
I was wondering when you ask, if you'd ask a mental health colleague who's frustrated they can't they can't complete a battery, and they're not prescribing anything, but you feel, is there a certain point where you feel it's gone to a point where you feel they have a mood disorder where they would want a medical intervention?
Yes, I see. I think then that would be, that's where I think cultivating the providers within your community to really be able to have good relationships, and for them to have good skills in understanding what, what people need. And if maybe, I guess I'm not trained or won't be trained to make the decision about whether or not someone needs medication or not. That's, certainly not my scope of practice, but I do think that it, having conversation with providers, also having stakeholders with aphasia and their family members a part of that as well to help develop that. But I do think if the one level isn't working, it's time to move up to the next, I guess is what I would say. So I agree with you on that.
Any last questions for Dr. Strong? I'm not seeing any come through, but if anybody thinks of any, you can submit them to us and we'll be happy to share them as well. I am going to share the screen again. And I just wanted to also thank everybody for listening today. And the recording from today will be available within the next 24 to 48 hours. We did get a late start recording. I apologize about that, but we did get some really great content recorded thanks to this presentation today that we're excited to share. I want to take this time as a reminder that our conference, our 101st annual conference, is coming up on, again, October 31st through November 3rd, with a pre-conference the 29th to the 31st. Otherwise, this concludes today. So please consider joining our group, our Stroke ISIG, and joining the ACRM annual conference. Be safe and stay healthy, and we hope to have you join us again at the next webinar. Thank you so much.
Thank you.
Thanks for having me.
Thank you, Katie. This was great.
Hopefully it hit where you wanted. So
Yeah, no, it was fantastic.
sorry long.
Oh, no, it's no worries at all.
It was great. Thank you so much, Dr. Strong, for doing this. I really appreciate it.
Oh, my pleasure. My pleasure. Thanks for your amazing work. And there were quite a few people on the call, which was great. So
yeah,
That's a great turnout. Thank you.
And thank you for allowing me to reschedule. I appreciate that greatly.
Oh my gosh.
Of course. Yes. Thank you for still giving your time. We really value it.
Absolutely.
Thank you. I hope
Have a
everything's
great
well.
week. Yeah, we'll talk to you
All
soon.
right.
Okay.
All right. Bye.
Take care. Bye.